How are you certain that your patients have received sufficient analgesia during surgery?
So I have no certainty that the patient has received enough analgesia during surgery. I'm fairly confident, using 30 years of experience, in deciding how much and when to give my analgesics, but I can be surprised at times. My dosing is based on the type of surgery, as well as patient-specific issues, such as are they opioid tolerant or opioid naive, their size, their age, other comorbidities, to decide how I dose. But my dosing is still an educated guess.
Which patients are more likely to suffer from acute postoperative pain, contributing to persistent and chronic pain post-surgery?
Well, orthopedic surgery and thoracic surgery, mastectomies, extensive resections in oncologic surgery, limb amputations are most common examples.
From your experience, which patients or types of surgeries tend to report the highest pain scores postoperatively?
Well, certainly patients with opioid dependency and frequent opioid use have the highest pain scores, as well as patients who undergo procedures where we cannot use regional anesthesia or blocks, such as spine surgeries, some GYN surgeries such as vulvectomy, etc. So in these situations, I'm always on the lookout for inadequate pain control in the PACU. It would be nice to have a purely objective monitor of pain, since the situation gets more complex because some patients report higher pain scores than they may actually have, because for a number of reasons. They may be dependent on opioids, seeking opioids, or they may just be fearful of pain. So they try and get their pain medicine up front. And that creates some risks for them and for us, such as critical respiratory depression. So a more objective pain monitor would be fantastic.
How often do you need pain rescue medication to be administered at your hospital?
Well, in PACU, this is far too common every day. 30 to 40% of patients are in moderate to severe pain in our hospital, which sounds bad, but it's actually better than what's reported worldwide, where up to 60-70% of patients suffer from severe post-surgical pain. This is data that hasn't improved since decades, and given the otherwise fast progress in medicine, is actually quite disappointing.
We observe it in a vast majority of our patients. It reflects how pain is still neglected and undertreated.
Where do you see pain-related opportunities for improvement in your own institution?
I think introduction of new drugs with a better side effect profile, say tramadol replaced with tapentadol, may be one option. The introduction of a more patient-centered approach to pain monitoring on post-surgical wards may be another one, where patients may be given the opportunity to directly submit pain scores to the pain team, leading to a faster, more targeted, more personalized, and hopefully more efficient treatment of this pain. And last but certainly not least, the intraoperative monitoring of nociception and pain, which is something close to my research heart really, which should help to stop this vicious cycle of patients waking up in severe pain, needing opioid medication, feeling sick, staying longer in PACU, and ultimately possibly even having more chronic pain after surgery. All of this could be stopped if you would get it right in the first place, intraoperatively.